Thank you very much. Thank you very much, Ali. Thank you very much, SAGES, for the opportunity to be part of such a prestigious panel today and give me the chance to share some thoughts and ideas on innovation in bariatric surgery. And here we go. So I have nothing to disclose. There we go. Okay. We'll go back one maybe. If you can just go back one slide. I have nothing to disclose beside a strong bias towards medical innovation. And this is a big portion of what I do, but it might not transpire from this talk. I've tried pretty hard to not be too enthusiastic about things that I'm going to present, and more importantly, maybe show the challenges that obesity represents as we're trying to develop solutions for this extremely complex disease that we don't fully understand. And what I want to try to show is that it's not only about challenging science, but it's also challenging business. And creating medical innovation, getting it to patient requires a business around it to make it happen. And that can be extremely, extremely challenging in this field. And to put this into a little bit of context, bariatric surgery is considered a more recent field, but it's close to retirement age. The first cases are described in the 50s with intestinal resections. In the 60s, we had the jejunal bypass with the outcomes that we all know about. And okay. Try again. Here we go. Everything has been probably tried, from jaw wiring to the more typical surgeries that we've heard about, the horizontal gastroplasty, the vertical one. I had never heard of the modified long VBG, which apparently there were more than 3,000 cases done. So I think the gastric bypass that we know today is not something that was developed overnight. It is the evolution of a lot of trial and errors and decades of surgical innovation, and this is why it's still, I think, the main and the gold standard of bariatric therapies. So what is new in surgical approaches? Well, the V-block has just been approved by the FDA about a year ago. The FDA trial was 157 patients with an excess body weight loss of about 24%, which was slightly under what they aimed to achieve, but the safety profile was good enough that the FDA approved this. But there are some challenges, and even after the approval, the company has been struggling to raise the huge amounts of money that they need to continue developing and making this device. A more recent surgical approach is just presented at Emerging Tech at ASMBS. This is a vertical clamp that is a metal clamp with silicone on top of it, and they clamp the stomach, sort of creating a combination somewhere between a band and a sleeve, with 44% excess body weight loss at 6 months, but they had to explant 7 of them because of slippage. This is a company that unfortunately you might have never heard about. This was a company that was started in the Bay Area called Vibrant, and they had an implant which was essentially something that you would implant underneath the fascia where the stomach is and create external compression of the stomach. They did a very well-designed 100-patient trial with 2-year follow-up. The excess body weight loss was about 34% at 2 years with a good safety profile. They had to raise $66 million to go through all this, and now the company's shut down because of regulatory issues in the United States and having trouble raising even more money to keep developing this platform. What about endoscopy? So the endoscopic sleeve gastroplasty, there's been a very recent publications from Abu Dhabi and others describing this technique, and these are very, very experienced endoscopists, probably some of the best in the country, and it still took them 217 minutes on average to start doing this. They got it down to a little over an hour and a half, but it's still not something that is the most efficient. And their excess body weight loss was, really good at 6 months. And they had some patients that they followed up all the way to 20 months. What's the challenge here? Well, the challenge was durability. You can see that some of the sleeves were already broken down at the 3 months timeline. And of the 8 patients that they have at 20 months, 3 of them had regained all the weight they had lost. The balloon, I'm not going to really talk about the balloon because the first balloons were in the 80s, so I don't think this is considered anything new. It's not because the FDA decided to approve them now that they're really a new technology. The Swallowball one might be a new technology. They just got CE marked. They started doing cases in France. Their initial trial was in 8 patients. This is a balloon that you swallow. It's then inflated with a little catheter, and it essentially after 3 months, the little valve is dissolved and empties and passes. So they retrieved all 8 balloons. All 8 were passed without any issues. But the excess body weight loss at 3 months was 25%. That was without a control group. And that's on patients with a relatively low BMI. Another endoscopic technique or technology. This is essentially a Gtube with a system to pump anything out from the stomach after you've eaten. Sorry, this is after lunch, I apologize. They've had a trial with 18 patients, 7 controls. At 1 year, their excess body weight loss was close to 50%. At 2 years, the 7 patients they had, it was 54%. For an endoscopic technique, it's not bad. The challenges here, 5 tubes were blocked at some point, 3 patients had skin infections, 4 had to be removed, and 1 patient has a persistent gastrocutaneous fistula. And it does look like this. I'm sorry, there is a concept about this that I don't find the most appealing, but if it works, it works. A more recent technology that is currently in development is called a transpyloric shuttle. So this is essentially the way you flush your bathroom toilet, and this will plug your pylorus when the stomach contracts. And they've done an initial 20-patient trial at 3 months, at 6 months, with 41% excess body weight loss at 6 months. Challenges here, they've had to remove 2 early because of gastric ulcers, and they've just started now enrolling their first patient for their FDA pivotal trial. The company had to raise over $35 million just to pay for this trial. And this is in addition to the $40 million they raised so far to develop this product. And their first patent that at least I could find is over 12 years old. So it's taken 12 years and so far $70 million to develop a technology that has even just started their FDA trial. Endoscopic sleeves, again, not really a big novelty. The duodenal sleeve, they've sold more than 3,000 of these so far. And again, $35 million raised just for the FDA trial. That included 325 patients. And in June, the FDA abruptly stopped this trial because of cases of liver abscesses. The esophagojejunal sleeve, which was it's just one that is implanted at the bottom of your esophagus and goes down about 120 centimeters and is supposed to replicate a gastric bypass. There was a 24-patient study in 2011 with good weight loss at 12 weeks, which is 3 months. There were 5 early explants for dysphagia. And the problem here is the last update on the company's website was 2009. So I don't exactly know where this stands. They did get some funding in September of a few $1 million, so the company's still somewhat alive. But again, this just shows the challenges of even if you have a good idea or a good concept, it's difficult to get these things all the way through. So what about a liner that is not even endoscopic? So what could you coat the mucosa with something? That sounds like a great idea. The challenge here is the only thing we know about that company is the name, and they're out of Baltimore. So we'll see where this ends up, but the concept seems appealing. What about a pill? So there is a pill, and this pill is interesting. It's essentially a hydrogel in a pill, and you swallow it, and it looks like this once it's sort of filled with water. This fills your stomach, creates satiety, and then as the hydrogel, which is dissolved over time, is supposed to coat your small intestine and reduce absorption. Challenge with this, here we go. They did a 128 patient trial, 3 arms. There was a control and then 2 different dosages. Relatively low BMI, at least for bariatric surgery standards. I wish I had 32 BMI patients to operate on. But this was a 12-week trial. The total body weight loss was 6% for the low dose, 4% for the high dose, and 4% for the controls. And the dropout rates was 5% for the low dose, but 24% for the high dose, and they were probably having some issues with compliance with the low dose pill. But it's a pill, so the complication rate is pretty low. So wrapping up and doing a 360, we're sort of maybe back to surgery, and this is a little bit outside of the traditional bariatric surgery field, but if you imagine the current technology of trying to tell the vagus nerves that your stomach is full, what about trying to tell your brain that your stomach is full? This is something that a few people are working on, including at Stanford. It's called deep brain stimulation, and some of you have probably heard of the technology. It's been applied for essential tremor and Parkinson's very effectively. So you put electrodes in your brain, and you have a stimulator with a battery pack that's implanted, and it sends it stimulates this specific area of the brain to reduce tremor, for example. So areas of the brain have been linked to obesity, including in the 70s, where a lesion of your lateral hypothalamus, which is called the nucleus accumbens, would induce weight loss. And this area of the brain has a role in what's called the reward eating. So the way that you eat and then you feel good and then you eat again, this is the part of your brain that essentially gives you that information. And if you stimulate that area appropriately, it will stop mice from binge eating. Again, this is mice, but they had a decrease in their weight, they had a decrease in their caloric intake, and obese mice were no longer obese with this technology. Again, the challenge here, so this was actually tried in humans, three patients who actually had failed gastric bypass. And they implanted the electrodes and started doing some stimulation. The patient number 1, speaking with the people who did this trial, the electrode was probably not placed exactly where it should have been, and the results were not very good. But this is 3 years out. When they measured the basic resting metabolism of these patients 3 years after implantation, it was increased. A couple of patients had really pretty good, this is total body weight loss, so 12 and 16% is pretty good. The challenge is, well, this is only 3 patients, and what they discovered is that the area that they have to pinpoint to stimulate is not the entire nucleus accumbens, which is relatively big for neurosurgery standards, but it's a small part of it, which is about 2 millimeters square. So you have to get this pretty close to where you have to go. So in conclusion, I think this little show and tell of weight loss therapies can show you hopefully how challenging it is, but also how important it is that we keep developing these technologies for this huge unmet need. And even if your odds of failure are probably bigger than your odds of success, that was the other way around, that's my optimism, I think we still need to keep developing, and this is what we're trying to do at the Biodesign program, where we teach medtech innovation in teams of engineers and doctors that we put together for an entire year, look for unmet needs and try to develop new devices, knowing that the challenges of FDA and creating a successful business around things are there, but it's not reason enough to stop. So thank you very much for your attention.